what terms you use with your patients. But I talk with my patient. This is not for the recording. This is just me workshopping. With my patients, I often try and say something along the lines of, there is a really, really rich nerve supply to the vulva, and nerves are very good at remembering. And so when there's been some form of trauma or to that area previously, the nerves remember that again in the future, and that can be kind of part of the picture. I was almost thinking about, could we...
Well, it's actually... So someone's actually done the study where they cut out the nerves, cut out the tissue, and it does clearly show that there's increased C fiber nerves in these areas. So some sort of trauma has then led to more nerves in these areas, which then kind of the same pressure on this causes the patient picks it up as severely uncomfortable or painful.
I'm just wondering how to kind of acknowledge what you're saying, because I think I might just say I've definitely noticed from patients I've seen with this that it can be a very debilitating condition. Or maybe we acknowledge that later. What were you thinking, Emma?
Well, I think vulvodynia needs a podcast of its own.
Yeah, I think that's what I was kind of getting at, acknowledging it.
I think, it's very complicated.
Yeah.
And primary, secondary often is triggered by an episode of thrush or an insult to the vulva, which long after that insult, there's ongoing pain. But that's sort of what you're saying, really.
I'm wondering, instead of me launching in and saying, Emma, as a dermatologist, did you want to kind of respond to Hong and kind of add that in, just so we get that kind of banter back? And
yeah. So after Hong says due to primary or secondary, and then Emma, you can say, for example, what we just said.
And then just say, I'm often,
Yeah.
So maybe Hong can start with the vulvodynia. Or Sarah, that's what causes either.
Or do you want to just re-answer that question? Is that what?
So are you starting with
what? You can probably just go from the secondary cause of vulvodynia.
Okay.
For patients with secondary vulvodynia, often they have been able to be sexually active previously, and then at some point onwards, they notice that every time they are sexually active, they get pain. Often this change in event has been caused by some sort of trauma to the vulval area, and this trauma can come in the format of chronic infections such as thrush, vaginal delivery, or painful dry intercourse. We do also know that in these areas there's increased nerves, so when the area is touched or triggered, patients will classically describe the sensation as a burning or sharp shooting pain that continues even after that pressure is taken away. So it does linger, and even after the pressure, it does linger even after the pain, the pressure is taken away.
A stimuli, or
it can the pain can still continue even after the stimuli is taken away.
Cool. Where was I? Emma, as a dermatologist, how do you encounter this clinically?
Well, we often get referred patients to rule out a dermatological cause of the pain, such as erosive lichen planus or dermatitis, but often we're looking back for that episode of trauma or infection that Hong mentioned. So we will go back and identify that they actually did have thrush, or they had a traumatic vaginal delivery and a tear, and ever since they've had pain with intercourse.
Hong, are there any treatment options for vulvodynia?
There are certainly a number of different treatment options, and we do know that with each of them, there is about a 60 to 70% effective rate. But when you combined all of these or a number of these together, the effective rate can improve. But it is also important to explain to patients that none of these are going to be quick fixes. It's going to take time, and often by the time they start a management, it can take a good 3 to 6 months before they start to notice changes. So often they will need a multidisciplinary team, which includes then a doctor that would help prescribe some of the medications, and the medications would be nerve modulators, including either amitriptyline, nortriptyline, pregabalin, gabapentin, some examples, and some of these can come in the format of tablets or compounded as a cream. And just being mindful that if you are using a cream, 10 to 20% can get a local burning reaction from the cream. Additionally to the medications, there's physiotherapy, and the physiotherapist will provide biofeedback, which often includes using dilators to help decrease the increased pressure around the ligaments. Psychologists can be quite important for CVT, and in a small group of patients, surgery may be an option, and these patients would have a vestibulectomy, or even the periurethral glands would be removed. There are emerging evidence also for other methods of management, including Botox, TENS and acupuncture, but there's limited research in these.
Have we mentioned herpes yet?
No, that's coming up.
Oh,
That's-
no, I
that's
was just
now.
going to say, as you mentioned.
No,
we don't think anyone
Yeah.
mentioned.
Doesn't matter.
Let's quickly touch on one of the other common causes of pain of the vulva that you mentioned. Oh yeah, I see. Yeah, okay. I don't know why.
Why don't we just say other common
just
causes
touch
of
on
pain on the vulva?
Yeah. Let's quickly touch on one of the other common causes of pain of the vulva, genital herpes. Sorry, I'll say that again. Let's quickly touch on one of the other common causes of pain of the vulva, genital herpes. How does this usually present?
Often it depends on whether it's a primary or recurrence, but usually it's painful ulcers or blisters, which can be single or multiple lesions. And if it's the first presentation, often they've got severe pain, difficulty in ability to urinate, and the vulva's quite red and swollen as well.
How do we confirm a diagnosis of a herpes simplex virus or HSV?
Well, clinically, you'll see typical features of a cluster of shallow ulcers on the vulva, including the mucosal skin, and this will be confirmed by PCR from a viral swab.
How is it best treated?
Antivirals is the mainstay, with either acyclovir or famciclovir as examples. If they've got multiple recurrent episodes, then they should also consider being on a prophylactic antiviral as well.
What are the signs of recurrence? Do you have to have a vesicle for it to be active, or is vulval pain alone a sign of recurrence?
Typically, a recurrence will result in pain in association with the vesicles and erosions and the other accompanying symptoms such as dysuria. You're most infectious when you have active lesions. However, there can be viral shedding 1 to 2 weeks after an episode, and even when completely asymptomatic. Reassuringly though, and it's important to tell women this, studies have shown that transmission of the virus is extremely low between outbreaks.
I often see first episodes of genital HSV in general practice. This consultation is often very distressing for those impacted. Hong, what advice do you give your patients with HSV in regards to future sexual partners?
Understandably, these patients will feel quite self-conscious about the diagnosis. Often I refer them to the Melbourne Sexual Health website, have some great information about how they can disclose this to their partners as well. So worth referring them to that website. But firstly, it's about being quite encouraging of patients to say that it's important for them to notify partners because then they're aware they can go and get screened if they do start to have symptoms. But also we do know that